Done. Thank you.
Anything else?
You're good. Thank you.
Maybe.
Misha, can you hear me?
Yes, we can hear perfectly.
Okay, this is part of the ground rounds that we're working. So this kind of very interesting topic because occasionally we see those patients with brain injuries and becomes a challenge from the ethical perspective, management, diagnosis, and assessment. So we're very glad to have also, besides the palliative care team, the neurology team for any additional recommendation, as well as the primary care team. So let me pass the microphone to Fatima.
Hi, how are you? Hi, everybody. Hi, Dr. Michelle. How are you doing? Thanks for coming. This is Dr. Moini. I'm from palliative medicine. So today we are going to discuss a case and to have a multidisciplinary approach to the case that we had recently at the hospital. We are doing case presentation. We have neurology team. We have neurology program director over the Zoom for questions and comments. Then we go to the goals of care for that patient and ethics principles by the palliative team, and finally we are going to conclusions. The case was a 64-year-old male with a past medical history of hypertension, diabetes, chronic AFib. The patient actually was brought by the EMS to the ER with the arrest. The patient was tracked at home while was eating, and then the family, the son was over there for EMS. Based on the family, EMS arrived within 15 minutes, and they were able to, when they arrived, the patient was asystole, based on the information they provided, and they were able to remove a large big piece of the meat steak from the patient's throat, and then they started basic CPR at the home, and they transferred the patient with ambo bag to the ED. When the patient arrived to the ED, he had pulse but unresponsive. So the ED doctors, they proceed to the intubation and then actually admitted the patient to the ICU. On arrival, they saw some generalized myoclonic movements and then started bolus like valproic acid and Keppra, and then the patient admitted to the hospital, to the ICU intubated. On the past history, the significant thing is the alcohol use. So the patient started the alcohol drinking at the age 9 to 12, and sometimes a lot, like 2 bottles of vodka per day, and recently his son, something like 6 to 10 beers per day. So on arrival, the patient was hypotensive even after intubation. Then they run the fluid, the blood pressure got better, then again hypotensive. Only the remarkable point on the physical examination, the pupil was not reactive to the light, and even at the admission, they couldn't find corneal reflex. The ABG at the admission showed metabolic acidosis. So the alcohol level was 261. The urine drug screening test back negative. The E-force data didn't show anything significant. So the patient was started on bicarbonate. The labs that we have, I can say the remarkable thing is a little bit elevation of the creatinine, a little bit elevation less than 2 times the AST, ALT, mild leukocytosis, mild anemia. This is the EKG that we have it at the ED, emergency department. That is the sinus rhythm with the frequent PAC. This is the EKG at the ICU, sinus tachycardia. This is the EKG, the chest X-ray, first chest X-ray, unremarkable, no consolidation, no effusion. The brain CT scan was done, and it showed that right subacute to chronic right frontal hypodensity is in favor of subacute to chronic ischemia. These are the CT scan, brain CT scan. The other significant imaging that we have it that was done on the first day was chest CT scan, and they found bibasilar lower lobe, bibasilar actually reticular pattern plus small pleural effusion in favor of atelectasia or in favor of superimposed infection. So the patient actually was admitted to the ICU, sedated, was on pressor, first only on the levoped on the first few days, antibiotic. So with the ampicillin, vancomycin, later changed to cefepime with the suspicion of aspiration pneumonia, with the history that they had it. They got involved many specialties on the case. Echocardiography was done normal. Echocardiography was done on the first day. These are the active medication that we have it. And the patient during the days of admission in the ICU was mainly on these medication. The only thing that I can add here, since the patient admitted actually at 10:30, was brought at 10:30 on the December 28th to the ED. And on January 2nd, the situation started to getting worse and with multiple episodes of hypertension, even the patient was on levoped. So they added vasopressin and epinephrine. And up to the end of the admission was on 3 pressors. So on the first day, neurology was consulted, and based on their evaluation, they evaluate the patient, and their assessment was, with the suspecting about anoxic brain injury, status post cardiac arrest, and central versus peripheral myoclonus. So they recommended EEG, they recommended MRI, another brain CT scan, and they recommended temperature management protocol. The first EEG that was done on the second day of admission was grossly abnormal because of burst suppression patterns throughout the recording, indicative of severe hypoxic ischemic cerebral injury. Neurology was evaluating the patient daily, so they were clinically unable to off the sedations because each time try to off the sedation to see how is the patient's brain function. They saw the generalized myoclonus, movement, but they did the brain stem test, the whole brain stem test on the sedation, and they found that there is no brain stem reflex. But they couldn't proceed to apnea test because the patient never been hemodynamically stable, always on 3 pressors, and always somehow mean arterial pressure a little bit low. So they recommended second EEG. They recommended brain CT scan, brain MRI, CT angiography of the brain, and transcranial Doppler ultrasound. That we couldn't do none of them because of the patient situation. The second EEG only was done on the January 2nd. That was abnormal again with diffusely slow, the superimposed occasional generalized sharp waves every 1 to 2 seconds with some rare sharp waves discharge over the right frontal temporal region. And they didn't see any epileptiform, abnormalities, and generally in favor of severe encephalopathy. During the admission, every day patient's condition deteriorated, so was hemodynamically unstable on 3 pressors, episodes of bradycardia, all based on metabolic acidosis, on bicarbonate, and on antibiotics. Okay, the patient on the January 4th, so on January 3rd, they did a chest X-ray again, and they found multilobar pneumonia that I have the chest X-ray here, multifocal opacity, bilateral, and then they changed the setting of ventilator to the setting of ARDS. We increased with the increasing rate of respiratory rate to 34, FiO2 to 100% from 40%, and PEEP to 10, but the patient is still hypoxic. And the ABG, as you saw, is metabolic acidosis. So the second is the second and the last chest X-ray that we have it here, the third and the last chest X-ray that we have it really in favor of ARDS, as I know. On January 4th, at the afternoon, about 6 p.m., the patient had BF, and then, they did the CPR. So here, the patient was full code, and the patient admitted at night on December 28th, but palliative was involved on January 2nd. The consult actually was placed on January 2nd in the afternoon, and we saw really the patient in the morning because we were not aware of that consult. So January 3rd, we were involved, and the patient in the afternoon of January 4th had code blue. During that 2 days, we had multiple times goals of care discussion with the family, code schedule discussion with the family, but unfortunately, they wanted to keep doing everything. After the first CPR, that was short CPR, about 9 minutes, we have this EKG 2 hours after that. That shows, actually was reported with white QRS with tachycardia, heart rate about 106, with left bundle branch block, but might be even, junctional tachycardia with aberrancy. So then they called, the ICU team called the family and informed them, update them, and on that time they agreed the DNR. And the thing happened early in the morning, the day after that, about 1:30 a.m. So the patient got, again, AF systole and was DNR and died at 1:30 a.m. So we are going to discuss this case to see how going to be our approach if we have the same case in the future. Any questions about the case? Thank you. I'm going to ask Dr. Dr. Amin, neurology, to continue.
All right. Sorry, I'm actually gonna present. All right, I'm just gonna go through. I made the slides. Everybody can hear me in the back?
Yes.
Yeah, okay. So the case was pretty straightforward. So all the steps were taken as it should. So now my presentation, they told us that neurology, hey, can you talk about, the brain death and anoxic brain injury after cardiac arrest? So, yeah, that's a really important topic. So that's what we're going to talk about today. And as if you have been here before, you know how relaxing that picture is. That was my balcony when I was a student.
Where?
Dominica. Okay, so I'm going to go through the steps. I'm going to go through the steps of consciousness and go step by step. The slides are pretty extensive. I put it as a reference. I'm not going to go through everything. So I assume that they're going to be provided with the slides. So I put a lot of references over there. Every slide has also the reference. You can go to the original source if you need more. So if I skip some of this slide, it's just for your later information. Okay, so I was looking for, okay, we go from the normal person fully conscious, but the first question was, okay, what is consciousness? We say, okay, the patient is conscious, the patient is not conscious. So I looked it up and that's what it came up. Consciousness is a being such that is constant question insofar that this being is being, so I don't get a word of that. And then I found out and said, that's the philosophical.
Guys, we can't see the new slides.
Oh, they cannot see the new slides. You see it?
Now we do. Yep. Thank you.
Okay. All right. Okay. So then I found out, yeah, there are different definitions, and that was philosophical definition of consciousness. Okay, so that's one of them. We're not going to deal with that one. We're going to talk about basically the medical one. The medical one says the normal state of consciousness, basically, again, doesn't really say what's consciousness. Comprise either the state of the wakefulness, awareness, alertness in most human beings. Let me move this one so you can see. Okay. Function while not asleep or one of the recognized states of normal sleep from which the person can be really aware. Now, we divide the consciousness to different levels. Okay, fully conscious to coma. That's the worst one. And definitions are over there. If you want to go later, but start with clouding, confusion, lethargy, obtuned, stupor, and coma. So based on the presentation, those are. But when we go, who can be conscious? Can a plant be conscious? Is that really a question? The simple question, the answer would be whoever has eye. Okay, the eye tells you that you can be conscious. Okay, so a lot of animals with not the multifocal eyes, but regular eyes can be function. And what the level of consciousness goes through, all different parts of the brain. As we know, one of the main one involved is the reticular formation system. It has the tracks that makes you awake and alert. The information over there for reticular information system. Now, the next state is vegetative state. You have used that many times. Not many times, but sometimes you have used it. Yeah, the patients in vegetative state, I assume that palliative care people have used that every day, yeah? So now the question is, the vegetative state is a clinical condition of complete unawareness of the self and the environment, accompanied by sleep-wake cycle with either complete or partial presentation of hypothalamic and brainstem autonomic function. So the patient might be awake, they might open eye, but they don't follow any command. They don't do anything. Okay, so that's gonna be through the vegetative state. And one thing I learned is when you're dealing with the patient, you don't tell the patient you're in vegetative state, you tell the family, yeah? So now guess what? When you tell the family that, hey, your mother, your father, your loved one is in vegetative state, the reaction is not going to be really that pleasant. Hey, you're telling my father is a vegetable? So use the newer term. Actually, they're recommending to use the unresponsive wakefulness syndrome. That's the new medical term for vegetative state. They can be used exchangeably. Now, the next one, when we go down through the consciousness, would be the coma. We talk about coma all the time. So what is coma? Coma is definition, is a lengthy deep state of consciousness. I'm sorry, I have to move this one so you can see it. Okay. A coma. Yeah, it's okay. So a coma is a lengthy deep state of unconsciousness. People in a state of coma are alive, but are unable to move or be aware of or respond to their surroundings. They lose their thinking abilities, but retain non-cognitive function and normal sleep pattern. Okay, how do I know they have a normal sleep pattern if they're in coma? REM, or EEG. Yeah, that can show us. All right, now, pathophysiology of coma. 3 things can cause coma. The first one is bilateral diffuse hemispheric disease. Bilateral hemisphere of. The second one is brainstem reticular formation disease, the one we talked about. And the last one will be the thalamic relay nuclei. That basically is the gateway for all the information to go up and go down. Now, everybody okay with those? Yeah. So now, if we have a patient that shows on the picture over there, how is he doing?
One hemisphere is normal, only right side.
In the back, come on. How is he doing? Not good, he's dead. Yeah, his brain is on the table. Okay, now let me correct it. How was he doing before dying? Let me tell you, he was not dead before being dead. Okay, so based on that brain, can you think he was in coma? What do you think that caused that?
We don't have brain.
Type of. Okay, what caused that? What caused this? What is this?
Herpes encephalitis, or
No, this is bilateral. Trauma, unilateral bleeding all over is trauma. Is the left side, so the right side, is the left side affected? No. So does it mean the first one? No. Now she said we don't have the brain stem. That's a good thing. By that one, I cannot say that the patient going to be in coma, yes? So then I have to go and see the rest of them. And actually the patient was in coma, and this is the picture that we go. So we go down, then we go to the ponds, we see, wow, there's a big mess over here. So all those ascending are gone. So are all gone, which means that patient must be in coma, and that explains it. Okay. Now, this explanation, that patient was due hemorrhage, doesn't matter to us. Now, clinical state of reduced responsiveness. The patient can be awake, which is open eyes, or asleep, not opening eyes. So if the patient is awake, can be because of 4 things. Abulia, frontal problem, something damaged to the frontal. They understand, but they don't act. You tell them to do it. The executive function is not going to execute what they have to do, yes? So they're not going to follow any command. Second one would be psychogenic. The third one would be locked-in syndrome. You have heard about that. And the last one would be non-convulsive seizures. If they have seizure and not shaking, that explains it. If they appear asleep, means the eyes are closed, the explanation can be drowsiness, stupor, minimally conscious state, vegetative state, awake awareness, and coma, or pseudo-coma, which is psychogenic. Now, let's go back to the case that we talked about here. Cardiac arrest and brain injury. That is huge, huge, huge. Why? Why that is huge? Because you see how many people get MI, yeah? How many people go to cardiac arrest after that? Or because of something else go to cardiac arrest? And you probably know this answer. What cells in the body are most susceptible to hypoxia? Neurons. They don't have a storage, they just rely on glucose and then go to keto. But the thing is, they are not going to last that long. So the patient is in cardiac arrest. What's the first thing you're going to start? CPR. That should be in everybody's mind. CPR. The patient cardiac arrest, the first thing is CPR. Yeah. Why do we do CPR? Same thing. Get the blood to the brain. Now, how good do you think the CPR that we are doing is effective? First of all, do you think we do it as we did in the first class? Do you think everybody put, the pad? Everybody, put enough pressure? That is something we should think of. I actually looked it up, and it was published. They did 200 cases of CPR because of cardiac arrest. 30% of compressions were in the recommended range. A little above 1/3 of the compressions are actually were in the recommended range. And the average, I need to minimize this one now. And 64% when in range of depth, the average rate was above target. The average rate was above target 55% of the time, 55% of the time only. So about half. The average depth was above and below target 1.4% and 34% of the time, respectively. Of the 200 patients, 125, 62% attained return of spontaneous circulation. Of those, 94 were alive 24 hours after. So what I'm trying to say is, one of the biggest problems is we're thinking we are doing the CPR, but we are not. If we don't push properly, the blood is not going to get to the brain. If the blood is not getting to the brain, it's the same as not being CPR. The rest, they're going to last. The muscles, they last. What we care is the brain and then the heart. Okay. It shows that how damage is going to start. So in 1 minute after stopping the heart, the brain cells begin to die. Still can survive. 3 minutes, the serious brain injury is going to be likely. In 10 minutes, many brain cells have died. The patient is unlikely to recover. And 15 minutes, the recovery is virtually impossible. And that is if you don't do the proper CPR. Okay. So when we get a consult that, hey, we got a patient, got cardiac arrest yesterday, ROSC in 25 minutes. Our expectation going to change a little bit. We're going to be, seeing probably a sad case. Same thing in a different format. Now, what is the top treatment priorities post cardiac arrest? It's a general question, not neurology. The patient come with cardiac, we did the CPR, ROSC achieved, what's the next step?
Hemodynamic.
What caused the cardiac arrest? Yeah?
Oh,
So if you don't fix the cause, then they're gonna return again. So the top treatment priority in early hours after decision include determination and revising the cause of cardiac arrest to prevent circulatory collapse and rearrest the maintenance of neuroprotective, hemodynamic, and mechanical maintenance. Okay. From neurology and post-resuscitation cardiac arrest, what do we do after that? We're always going to be consulted. Not always, but if the patient is in coma, if it doesn't come back. So what we do are basically in these 6 things. First is early assessment of the brain, followed by advocacy of the maintenance of the neuroprotective thermal, hemodynamic, biochemical, and metabolic milieu. The third will be detection and management of the seizures. Seizures is very important because of the brain injury. Development of an accurate
How do you decide that? No, we pick first. I'm taking the wrong answer. We did okay. No.
Okay. At least we have the power to mute them. All right. So detection and management of seizure, development of an acute multimodal and conservative approach to prognostication, application of shared decision, because this is a team. This is a multidisciplinary team. Basically, everybody is in the case. Yeah. You have seen those cases. You know how many consult gets done every day. Application of shared decision-making paradigm around the likely outcome of therapy and the goal of the care. You have to have an estimate that, hey, how it's going to be. And facilitation of the neurocognitive assessment of the survivors. After they're gone, when they go out, what do we do after? So generally, what we do, one of the important things is temperature management. Previously, what we were doing is cool them down as much as possible. The reason behind it was reduce the metabolism. The brain cell doesn't need that much energy, so they have the cover, time. It's actually changed now. They're saying hypothermia or normothermia. Definitely make sure they don't get fever. As far as they don't have fever, now we are good with the temperature. Metabolism. So we should normalize the biochemical, metabolic, and hemodynamic parameters. As you know, the oxygen, the pH, and all those things are important. Hyperventilation was another thing that has been changed. Previously, we were doing is hyperventilate the patient, give more oxygen because the brain needs more oxygen. Then they find out, wait a minute, if the brain gets too much oxygen, what's going to happen is very sensitive. Vasoconstriction happens. So I'm actually going to have a paradoxical result. So now there are trials going on that, what about if we do actually hypoventilation? Why? Because when the brain is the first one to act. If it's hypoventilated, then the blood vessels open in the brain, you're going to get more blood. That's not, but that's one of the things that is going on at the moment about hyperventilation. Seizure depends on the patient. A lot of them get seizure, and believe it or not, a lot of them get a status epilepticus, means the seizure going on. And the worst thing is a lot of them are in paralytics. They are seizing, but you don't see them. Maybe you see the tongue, maybe you see the eye, but a lot of times it's missed. So in a lot of hospitals now, they say if the patient is post-cardiac, in coma, and is in paralytic, do 24-hour EEG. So in case they're seizing, we see it and we go, we do something about it. All right. The next one is myoclonus, like this patient had. This is bad. If you see the patient in coma and had myoclonus, it's like a sad news. Okay, prognosis suddenly go down. So although myoclonus once considered marked fatal cardiac arrest, some patient with severely early myoclonus achieve adequate functional recovery. Phenotype and myoclonic not fully understood, presence or type of finding on EEG may define different prognostic groups. But generally, when you see myoclonus in those patients, post-cardiac arrest, not a good sign. Prognostication. So the first thing the family gonna ask would be how the patient gonna do. That's the first thing, and also other things, yes? So there were studies done. This one was done in Cornell in New York, and that's one of the ones that was published. And they did 387 patients, and they say, okay, any three reactive, if they have any of these, corneal, pupil, oculo, vestibular, motor, if you don't have those reflexes, then, can I move this?
That's the up arrow on the green box.
On the green,
On the left. On the left of the green.
this one?
Yes.
Okay. Okay, on this one, you see recovery, number of patients, 2% got the recovery. 2% got the good recovery. If you don't have those reflexes, if you have the rest of the reflexes, the percentages are going to be changed. And then this is right after. This is right after. Then, is thinking. Okay. All right. So right after, or 7 days after, I'm sorry, I think I jumped this. Let me go back. And this one was 3 days after. Gonna go to 0%. The first one was right after. This is 3 days after. And this one is 7 days after, which is basically gonna have zero chance of having a good recovery. The rest gonna be in severe or be there. Okay, EEG. Oh, one more thing. They actually did a new study. I didn't put it in this one. I think I should have put, but they did a study and say, okay, when the doctors go over here and they do that, first of all, a lot of us don't do the proper, honestly, we don't do the exact proper exam. Okay, so that's one thing, the human error. The second thing is, based on this, I'm gonna have the assumption that this patient is basically done. So what I'm gonna do, I'm gonna minimize my effort, yeah? So I have to find out a study, but it's a very good university. It says that every year, because of this assumption, 3,000 people die that they could have recovered. Because we just assumed that, hey, they're not gonna be good based on that chart. So we didn't do that much for them. What should we do? They're already gonna die, you know, what's the progression? So they find out that 3,000 people actually died because of our assumption. Okay, EEG, it shows the background, how the brain overall is doing, if something is going on. They do the enolase in 24, 48, and 72 hours. The level 20, 40 is acceptable. If it goes up to 80, the prognosis is going to go down. MRI, our best friends. So a neurologist best friend nowadays, one of the best friends, should be performed between 3 to 6 days in patients who remain comatose. MRI is especially useful when patient on anti-epileptic agent that interfere with examination. So you remember, like our patient, we could not really do the full examination. MRI would show me the brain. All right. There are 2 cases over here. And after, if they recover, they need to do cognitive tests because a lot of them are going to have cognitive issues. All right. Now, one thing over there is essential of how to approach this person. First is to get the full history. Definitely not from the patient, yeah, but from somebody who knows the patient. So we get all the history, pace, toxin, drugs, trauma, fever. I'm talking about the fever, not these are general. Then I get to a coma patient. Okay, not to the cardiac arrest only. Then the next most important thing is neurological examination and observation. That was there's something that we're gonna look. The posture is comfortable or on a tooth. A respiratory pattern, normal, periodic, hyperventilation, apnestic, ataxic, apnea, automatism, yawn and sneezing is good. Cough, swallow, and hiccup is bad. All right, those are the physical exam. The neurological exam, mental status, does it respond to voice, does it respond to pain, does unusual respond? That was my story. I was medical student and I was, in ICU and I don't know, neurologist or ICU. Okay, go do physical exam, neuro exam on this guy. And then, and the guy's in coma. And I'm looking at him. He's dead or not dead, breathing. Oh, really, what exam can I do next? So I did, look in the eye and those, things that we do. And I come back and said, okay, yeah, the eyes were likely active, but nothing else. I mean, nothing else. I don't know. He was, not moving. And that then he got so upset. I said, no, you can do a lot. You can do almost all the cranial nerves. I said, really? Yeah. They said, all right, how do you test for one? I said, no, you cannot test for one. Okay, I'll give you that. But how do you test for two? Flash of light, yeah. The 2 takes the 3 and all those, helps. So 3, 4, 5, pupils, size, and reactions. You have to explain it clearly. Eye movement. Do not turn the head. Is recommended not to turn the head because when you turn the head, they're intubated. Yeah, you might cause some damage, some blood gonna shove up. So it's easier to do the caloric test. You remember the cows? Anyway, cows.
Cold water opposite, water same.
Cold opposite, warm same. So what you do is easier to put cold water because you put ice and then you put water in it. In the hot, you don't really know the temperature. You don't want to put a boiling water and burn them. So they put ice, it should be ice because we know ice is basically 0 centigrade. And put water in it and then 10 to 15 cc's, put it in the ear and anteriorly. Push anteriorly and look at the eyes. The eyes cold is opposite. They should come to it and the correction fast will be opposite. That's normal. How can you do it? You can do it on all the residents, yeah? Yeah, you can do it. Then you remember, if it does that, then it's normal, unless you think that all the residents are normal. But you can do it. If it doesn't show it, then we have a problem. Corneal reflex, gag reflex, swallowing, and the 11 and 12 not really that much tested. A spontaneous movement. Another thing is the next day I go and did all those exams, come back to say, yeah, the brain stem is like this. What about the movement? He's not moving, he's sedated, yeah? I said, okay, then you have to turn off the sedations. Look, as neurology, we hate sedations on these patients. We want them to be on the minimum amount of sedation, opioid, everything, for the brain to gain function as much as possible. It's like talk about, we want more, we want less, nurses definitely want more, we want as little. So I just go over there, turn it off for like 15 minutes, and then come and punch the patient, do something noxious stimuli to see if there is any withdrawal. If there's a withdrawal, I get a movement, yes? So sensory comes, movement comes. I can get it that way. And also the reflexes. Reflexes doesn't need the brain. If they're not in paralytics, reflexes should be there. But if they're in paralytics, you don't expect reflexes. The sensory system, reflexes, glaucoma skull, lab studies. Okay, now the last thing is if they don't work like in our patient, then we are dealing with brain death. Brain death. So we had this thing with us. The patient can be pregnant or not pregnant, can be dead or not dead. It can be kind of dead, yeah? We made that example all the time. So now tell me, if you say the patient is brain dead, what is that then?
Yes.
Anybody understand the back? So when we say the patient is dead, it's not maybe, kind of, sort of, no. Now, who defined what is dead? That'll be the next question, because we don't have dead or kind of dead, yeah? Yeah, dead or alive or not dead. So who defines death?
Brain.
Hmm?
Brain death means like.
No, the death by itself. The death means you put the certificate, patient goes to the morgue, yeah?
Any doctor can.
And then, see if they're breathing.
Actually, partially true, but death, because he said it's not only you, it's also the patient gonna go to somewhere, a lot of legal things. So it's a legal and medical term. It's a combined. It's not just medical term. So when it's legal, when it's medical, means medical associations get involved to define the criteria. When it's legal, means the government, the Senate, those agencies should have a regulation to define what is death. So this is how government define death. Maybe it's new for some of you. The death, that's a Uniform Determination of Death Act of 1981. That's the law, okay? It says, look, a standard for determination of death. So when you sign a death certificate, an individual who has sustained either of these two, one, irreversible cessation of circulatory and respiratory function. That's what we know, yeah? No heart working, there's no brain. So that's the first one. The second one is irreversible cessation of all functions of the entire brain, including the brain stem. Actually, that's definition. Either of these two, this person is dead. Okay. So yeah, you go over there, the patient is, the heart is working, pumping, but it's dead. And when it's dead, then a lot of things gonna be changed. Okay. Now, who thinks how do you think when was the first brain death was described? Who thinks it's more than 3,000 years ago? 2,000 years ago, 1,000 years ago, 500 years ago, 100 years ago, 50 years ago, yesterday, today. I should put multiple questions. Okay, when does the first brain death was basically like described as a case report, as a story or something? Give a guess.
3,000?
3,000? 3,000? In the back, tell me. 3,000 because the writing coming 3,000, maybe, yes, that makes sense. That makes sense. Okay, so it actually is only 50 years old. No, hold on, what happened? Okay, I don't know how to move. Okay, the first brain death was described in 1950s. Why? The brain death is dead. How do you keep the pump going? By the ventilator. Did you have ventilator 3,000 years ago? Maybe 30,000 ago, but no, not 3,000 years ago. So after the ventilator comes, they find out that, hey, there's some patients, they're on ventilator, but nothing else is working. So that's the reason. It's kind of new. It actually got me too. Very suffer. So, and then 1950, Murray, they described it. 1968, Multidisciplinary committee. Harvard in 1968 put a criteria for brain death. And then now there are different agencies that define the brain death criteria. One of them is our organization, AAN, American Neurology, American Association of Neurologists. The second one is the neurocritical care. The third one is the Work Project. Now the Work Project came 2 years ago and said 3 years ago and say, okay, this is our guideline. And also each state has its own guideline because we said it's a legal and medical. It's a legal and medical. So when you want to say someone is dead, you have to meet all those criteria. All right. Now, one important thing is the most important. Do not pronounce death by brain criteria until you know the cause of the coma. The patient is in coma, but you have to know why they are in coma. Otherwise, you cannot say they are brain dead because severe cases of barbiturate toxicity and hypothermia look exactly like brain death. That's when you see that picture. It says, the stamp on the coffin says, certified death by the physician. And the patient is coming out of the coffin. Okay, now when we go to the brain death, because illegal, there are a lot of confusions. One of them is number of examiners who need to examine the person to sign the paper, whether or not consent for the exam. Next one is appropriate use of ancillary testing and choice of ancillary testing. Okay, they talked about the ancillary testing in that example in our patient because they couldn't finish all the criteria. Each of those organizations, they have a checklist. You go to the checklist, you pick something, you fill out the checklist, and it's a legal thing. You cannot mess up that thing. You're kind of killing someone if you mess up, yeah? Because you have to make sure that that person is dead. There's no way they come back. Because when you sign it, what's going to happen after this is finalized? The patient is dead. Yes? So what is the role of palliative care at that level? Nothing. Because this is actually what happened. The contact can say, we want to talk about brain death by palliative care. And I told him, you sure? I said, why? I said, your palliative care. Brain death is dead. You know, it's like, doesn't go together. All right, so these are the slides I put based on the state of Florida and most of the hospitals in Florida. So they follow the state. So AAN, World Project, and the state of Florida. So in each of these criteria, what are the differences? One important is EEG. EEG is not acceptable by the World Project. Okay, actually the World Project recommend against EEG because it says it doesn't record the posterior fossa. All right, most common etiologies: hypoxic brain injury, hemorrhagic stroke, ischemic stroke, traumatic brain injury, bacterial meningitis, viral encephalitis, hepatic, obstructive hydrocephalus, and cardiopulmonary arrest. Some of the medication that mimic it, ancillary testings, they are all listed over there. And these are the full really comparison between all three, the AAN, the WARD, and the critical care neurology. So these are for references over there. If you need it, you can go, and they're all over there. Very good resources. So in summary, neurological clinician has key role in care of patients who have experienced cardiac arrest, including early risk stratification, advocacy for targeted temperature management, normalization of biochemical, hemodynamic, and metabolic parameters, and detection and management of seizure, conservative prognostication, and referral for cognitive evaluation. Okay. Oh, and that's another one on the island. That was the other side of the building. Break of that.
Thank you.
Thank you, doctor. We have some extra references here.
So I'm on slide.
Where am I?
A different file probably.
Yeah, I believe it's in different file, no?
Yeah, it should be in different file.
No.
Perfect.
Just make sure share.
I don't know.
Share screen. Just listen, share.
All right. Patines, no son ahí. Patines. So, thank you so much, Doctor. It was a great presentation. So, as Dr. Amin said, why palliative care was involved in the case? Are you able to hear me, guys? Are you able to hear me? So, as Dr. Amin said, why palliative care was involved in the case? So I'm gonna talk about how we as a palliative care physicians approach this case and the ethical principles, and how do we talk to the families and what to do and how to do it, right? So do I need to use a microphone?
Yes, actually, so
Can you hear me in the back?
Oh.
Yeah. Okay, it's okay. So I'm gonna briefly summarize what we have. So we have a patient that was admitted on the 28th, sorry for the mistake. The patient had a cardiac arrest, the patient got the CPR, the patient survived, but the patient is in a very bad shape, okay? So the initial consult was neurology consult the patient was under sedation, mechanical ventilation, the EEG under sedation was normal, but then the patient got lactic acidosis, the patient was intoxicated, ethanol intoxicated, and the patient was using vasopressors, hemodynamically unstable under sedation, right? So that's what we have. Then the second or the third day after that, the patient continued hemodynamically unstable under vasopressors. Neurology recommended a second EEG plus any other ancillary test, right? And then we were consulted. Why? So basically what we do here is what we do with all the patients that we receive. First of all, we go over the proxy. Who is the proxy? Sometimes, like in this patient, is very simple. It was the son. Sometimes it's not that simple. Sometimes we need to go over, relatives, phone calls, etc., and we ended up with an ethical committee, social worker, and so on. But in this case, it was very easy. It was the proxy. So we know that it was the son. So we know that the son is the one that is going to make the decisions, right? And then second, we always go over the code status. So those are the first two things that we review. In this case, the patient was full code, all right? So code status and hospice eligibility, and I'm gonna talk about that later, were discussed with the proxy. Proxy wanted full code for his father, and he rejected hospice. Despite we talk about the risk of having a patient under artificial prolongation of life, we talk about the risk of chest compressions, etc., etc. But remember that we are human beings, and this is a process. So in many cases, during the first meeting, the proxy is going to say, do whatever. It's a process, right? So we need to have communication skills. And sometimes we forget that we are all human beings, right? So that's very important. So at this scenario, at this time, full code, do whatever, and no hospice. That's what we have. The next day, the patient remained hemodynamically unstable. The systolic blood pressure was under 90. The second EEG showed severe hypoxic ischemic cerebral injury, and the patient were officially under the assessment of a brain death, right? He got first code blue, the patient survived, and at this point in time, we talk again to the proxy, the proxy said DNR, okay? He got the second code blue, and the patient expired, right? So that's basically the scenario. So we have a patient that we suspect he got brain death, but it was not confirmed. So that's what we have, right? So as Dr. Already talked about that, I'm gonna briefly, again, summarize the definition of death, right? So the Uniform Determination of Death Act, as Dr. Amin said, defines death as an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all the functions of the entire brain, including the brainstem, right? So brain death, defined as the absence of clinical brain function when the cause is irreversible, is a common scenario in the ICU setting, right? Following severe traumatic brain injury, aneurysmal subarachnoid hemorrhage, balloon carotid injury, or in this case, hypoxic ischemic brain injury, right? So there are many publications about the brain, the death definition, the brain death definition, and this is something that has been changing over time, like Dr. already said. So first of all, the concept of irreversible coma showed up. We're talking about 1968. Then in the 80s, in 1980, the Uniform Determination of Death Act, as I said, two things: cardiorespiratory cessation or brain cessation, all right? Two of them. And then in 1995, the American Academy of Neurology specified these are the brainstem reflexes that you need to address, right? This and that and that and that, like Dr. already said. Then in 2010, the American Academy of Neurology said that the evoked potentials were not an ancillary test anymore, right? Feel free to correct me if I'm wrong. Okay. Finally, the World Health Organization in 2014 published why brain death is considered death and why there should be no confusion. We already talked about that. If your brain is not functioning and you don't have brainstem reflexes, you're dead, right? It's a legal concept. So the guideline, they published a guideline of clinical criteria on the determination of death, and they suggest that there may be few ways to determine death, but there is only one way of being dead, right? So the two classic pathways, which is the brain death and the circulatory death, merge into the same thing. And I'm going to show you. This is what I'm talking about. So in one hand, you can see the neurological arrest that ends in death. And in the other hand, you can see the cardiorespiratory arrest that ends in death, right? So this is, Dr. Amin already talked about the determination of the brain death, but I'm gonna briefly go over, okay? So as Dr. Amin already said, we need to be very sure that the condition is irreversible, right? So we need to rule out any CNS depressant drug. This patient was under ethanol effect. Should be no current administration of any neuromuscular blocking agents. Should be no critical electrolyte, acid base, or endocrine disorder. This patient persisted with a lactic acidosis, for example. Ensure normal or at least no fever, temperature, and normal systolic blood pressure. That was the main issue with the patient. We couldn't perform the apnea test because the systolic blood pressure was under 100, even with 3 vasopressors, right? Then we go ahead and perform the neurological exam, as Dr. Amin already explained. So the patient is no under sedation, is no under any drug. So we consider that the patient is having a good temperature, the patient is having a good blood pressure, so the patient meets the criteria to perform the neurological exam. No lactic acidosis, okay? No ABG's abnormalities. So the neurological exam can be performed. So as Dr. Amin said, usually we go over, all the brainstem reflexes to determine if we have brainstem function. So in Florida, under Florida law, we need 2 physicians, all right? So first, one of them should be the treating physician. In this case, it was internal medicine, and the other one can be either a neurologist, neurosurgeon, internist, pediatrician, in the case of a pediatric patient, surgeon, or anesthesiologist. So keep that in mind. Under Florida law, we need 2 physicians, right? So we need to have this in consideration. First of all, the coma, and then the absence of the brainstem reflex. The pupillary response, oculocephalic testing, oculovestibular testing, absence of corneal reflex, absence of facial muscle movement, lack of laryngeal and tracheal reflexes. Okay. Then at this point in time, if we assess the neurological status of the patient and we consider that the patient has no brainstem reflexes and all the setting has been reviewed, no alcohol intoxication, no drug, no sedative, no neuromuscular blocker agents, etc., 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 and we have no brainstem reflexes, then we can proceed with the gold standard, which is the apnea test. And this is a board question. This is very important. The gold standard to determine the brain death is the apnea test. You can use the ancillary test if, based on your criteria, you think you need it. But if you think that you don't need an ancillary test, they are not mandatory, at least on the Florida law. Am I right? Yeah. So the gold standard is the apnea test. So again, ensure hemodynamic stability, normothermia, or at least no fever. We normalized the PCO2 levels, we pre-oxygenate the patient, we got a baseline ABG just to confirm that there are no lactic acidosis, no hypoxemia, etc., 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 and then we disconnect the patient from the ventilator, right? We closely monitor any respiratory movement. Any sign of respiratory movement indicates brainstem function. So the time frame is controversial, usually between 8 to 10 minutes of apnea, and we obtain another ABG. And what we need to look for is for the rise in the level of PCO2. So any increase of at least 20 millimeters from the baseline, or if the PCO2 reaches 60, that is a positive apnea test. Okay, so I want you to think about this scenario. We go ahead.
And how long between the 2 exams and
You're talking about the neurological examination and the apnea test?
because in Brazil there are two exams too, the law
Yeah.
in Florida, but until 2018, 6 hours apart between the first and the second exam, and after that 1 hour between. In Florida, how long is it?
I'm not sure about that time frame in Florida. I don't know if you guys know the time frame between the first and the second neurological assessment.
So the neurological assessment should be done first, let me clear, by 2 different teams, not only 2 different physicians. So if I, have another, and they have to be trained and licensed. So it's not a resident thing.
Doesn't matter the time.
Yeah.
So
So first of all, our group go does it, and then I'm not sure, I have to look that up, but it's 6 hours or 24 hours. We can check that out.
24 hours what they're using the ICU. I have to go and check that.
Thank you, doctor. So I want you to think about this scenario. We go ahead, we perform the neurological examination by 2 physicians, and then we did the apnea test. And the apnea test, the ABGs came back, and you realized that the apnea test is positive. Again, is the patient dead? Yes, the patient is legally dead. But you go ahead and you connect the patient again, right? So the patient is under mechanical ventilation with vasopressors, and you have a family outside, right? So this is a very common, unfortunately, scenario. So I'm not going to talk about the ancillary test. Dr. Amin already did. Okay, again, under Florida law, they are not mandatory, only based on your criteria. If you consider that you need to perform the ancillary test, either because you're not sure about the results of the apnea test, or the apnea test is not conclusive, you can go ahead and ask for the ancillary test. If we have a patient that doesn't meet the criteria for the apnea test, then you can go through an ancillary test. But they are not mandatory. It's based on your criteria. Okay. I'm not going to talk about that already. Dr. Amin did it. So there are few different physical findings that can bias the results of the test. You already talked about that. Sometimes we misinterpret the test and the patient is dead, and it's not, right? So be careful. Spontaneous limb movements, cyclical dilatation and constriction of the pupils, respiratory-like movements, sweating, blushing, tachycardia, normal blood pressure, deep tendon reflexes, and Babinski, they are not considered signs of brainstem function. Okay, we need to be very careful. And also the opposite. We need to be very careful of saying, oh, there are no brainstem reflexes. Are you testing the brainstem reflexes well? So we need to be very careful of this, right? So I'm going to talk briefly about the legal controversies, and then I'm going to go over our palliative approach. Okay, remember, as doctor said, variations between states and countries, pregnancy and pediatric population, they are always controversial. And then the religion. Just for our knowledge, New Jersey is the only state that allows declaration of death only on cardiorespiratory criteria if personal religious belief do not recognize brain death. In other words, New Jersey is the only state where the physicians needs to respect your religion and your personal beliefs about brain death. Other than that, if the apnea test is positive or the ancillary tests are positive, the patient is legally dead. Okay, just for our knowledge. The consent for testing is very important. Under Florida, you don't need consent. You need to inform that you're going to perform a neurological exam, and then you're going to perform an apnea test. You need to inform, but you don't need to the consent, right? It's very important. And some clinical conditions that may bias the result of the apnea test, any severe facial trauma, pre-existing pupillary abnormalities, for example, or any toxic level of any sedative drug, we already talked about that, or the baseline condition. If a patient has, for example, a sleep apnea or any other condition resulting in chronic retention of CO2, be careful with that, okay? Again, so unfortunately, in this patient, we couldn't perform the apnea test. The patient passed away. We couldn't confirm the brain death. So I'm gonna bring here two possible scenarios, and I want you to help me. Okay, so this is a scenario number one. Let's say that we talk to the proxy, we go over the code status, we talk to the rest of the team, we review the case from the top to the bottom, and then we have a family meeting. That's how we usually do it, right? So during the family meeting, we discuss hospice eligibility before the apnea test. And why do you think it's important to discuss hospice before the apnea test? Because if you perform the apnea test and the apnea test is positive, the patient is legally dead. So you cannot admit a patient under hospice if the patient is legally dead. So if you're suspecting that the patient is brain dead, go ahead and discuss hospice eligibility before proceeding with the apnea test, right? So that's what we usually do. We talk about the clinical status of the patient, neurological assessment, and we go from the top to the bottom. And when I say from the top to the bottom, I mean that we start with the brain function, and then we go all the way down. The brain in your father is not working well because he had a cardiac arrest, and the brain lack oxygen and this and that, and then we go all the way down. The heart is not working well because your father needs 3 drugs to maintain the blood pressure and blah, blah, blah. Then we go with the lungs. Your father is under mechanical ventilation because the lungs, this and that, and then we go with the kidneys, and then we finish with the skin, any wound, any infection. So this is how we usually, get to, address all the patients, right? So usually we do 1, 2 family meetings. Sometimes we do many because it's a process, okay? So the more communication skills you have, the easier it is, right? So we talk about the prognosis, we talk about the ethical principles, and I'm gonna show you a few slides about it. We offer spiritual support, and then let's say that we inform about the apnea test. We say we're gonna proceed with what we call apnea test. We don't need consent. We go ahead, okay? And let's say that we perform the apnea test with or without the ancillary test, and the test is positive. So we have a brain death, right? What to do? What's coming next? We all know that what's coming next is extubation because the patient is legally dead. But again, we at this point need to remember that we're human beings. We need to give some time to the family to digest the information. Sometimes we are rushing, we want to extubate the patient, and this and that. We're human beings. So that's how palliative care, approaches. We talk again to the family, we explain the concept of human death, of brain death, and we explain what an extubation is, and this and that and that. Do we need consent for the extubation? No, the patient is legally dead. But we are human beings. We need to be in the same page with the rest of the teams and with the family, all right? Determination of death, and this is very important. The time and the date of the death is where you perform the apnea test and the PCO2 reaches the level. And when you confirm that the apnea test is positive, that is the time and the date of the death. Even though you're going to connect the patient again, the time and the date of the death is where you confirm that the PCO2 reaches the level. And this is very important. If you couldn't perform the apnea test and you confirm the brain death through ancillary test, the time and the date of the death is where the well-trained physician read the ancillary test and confirm the brain death, even though you're going to connect the patient again, okay? Scenario number 2. Let's say, like in this case, and for me, this is the most challenging one. We go over the proxy, we go over the COVID status, we do the family meeting, we explain hospice eligibility, prognosis, this and that and that and that. And we couldn't confirm the apnea test because the patient didn't meet criteria for the apnea test, or because we did the apnea test, but it was negative, or because the patient has brainstem reflexes, or because we are not sure, is inconclusive. We don't have brain death diagnosis. What to do? We have a human being that is legally alive. and it's connected, bad shape, vasopressors, we know that it's irreversible, and we can't go ahead and extubate. What to do? For me, again, this is the most challenging scenario. Again, the close communication you have, the closer communication you have with the family, the easier it is. We need to be in the same page. And these are the cases that ended up in the court if there is no agreement between physicians and families. So to prevent that, we need to have communication skills, we need to explain, we need to give family time to digest, we need to understand the process, and we need to convince the family that this is irreversible. So we're going to end up extubating the patient, but we can't proceed without the consent of the proxy because the patient is legally alive, right?
So I had a situation like this during one of my ICU rotations. Patient came into the ER, was dismixed, got intubated, and when we called got transferred to the ICU. Later, when we contacted the proxy was like, he never wanted to be intubated. I want you to extubate him right now.
Okay.
And we had called him actually for a consent for a central line because the patient was requiring pressors. So we tried explaining to the relative as to why we cannot just do it. And why central line was important and stuff like that. He said, I'm going to be there in a while. And once I get there, I want this patient extubated.
Okay.
I want my uncle extubated, and he was the next of kin for the patient. And once the relative came to the ICU, they saw the patient and they're like, no, I want withdrawal care. I want him extubated right now. I do not even want to wait for hospice, palliative, anybody coming. I want this to happen right now.
Okay.
In that situation, how do we proceed with this? How do we proceed from there?
Yeah, first of all, you need to ask for any advance directive that the patient did when the patient has capacity. Any living will, any healthcare proxy designation in hard copy.
Okay.
If no, you can, based on Florida law, designate the proxy if it was the son, and that was the proxy's wishes, you need to proceed.
Okay.
Okay.
So if they sign the withdrawal care at that point, they're signing the documents and everything, then are we legally allowed to extubate the patient?
If the proxy says yes, yes.
Okay, so we don't have to legally wait for hospice palliative to come evaluate the patient.
You can put the consult.
Even
And we
if
can
put the
help.
consult and say the family does not want to wait until they come and evaluate. So can, as a say critical care team, are we legally allowed to extubate the
So-
patient? That's my question.
What family medicine and ICU team and the primary team usually do in these cases, because we have seen cases like that, is that they put the consult with us and we rush
Right.
to the hospital and we talk.
Right.
Once we are involved in the case, we take care of this proxy designation, code status, extubation. But long story short, if the proxy says extubate, and there is no advance directive signed by the patient,
Right.
is the proxy's wishes, you go and you extubate, okay? With or without hospice, with or without palliative. Usually, again, they put consult, we rush. We have been in that situation 3 a.m. in the morning.
Right. No, I remember I spoke, actually,
Yeah.
I remember calling Dr. Burgos about it.
That was I guess a little thing, no? That was the one in Pennsylvania?
No, it was, I think so. You were out of town that time. Yeah. And you're like, I'll send the fellow right now. And the fellow's gonna be there in 20 minutes. The family did not want to wait even 20 minutes.
No,
Yeah.
it's okay. I remember it is an artificial prolongation, so it's something that is artificial, right? So
Right.
if the patient and the advanced care planning, then the living will say they don't want to proceed with that, we have to respect that.
Okay.
We have to respect it.
Yeah.
Understood. Okay, thank you.
So in the opposite case, that this is a scenario, let's say that the patient is legally alive and the family doesn't want to disconnect. The family wants to proceed, full code, mechanical ventilation, this and that. What to do? Close communication with the team. Any extubation attempt Yes or no? How is the clinical condition? How are the rest of the organs? Any sign of declining in the condition, any wounds, any infection? Because those are tools that we have to talk to the family. We can say, hey, listen, your father has had 3 or 4 or 5 extubation attempts and nothing. Or we can say, hey, listen, the rest of the organs are, going down. So it's a process. It's not from one day to the other. Controversial scenarios, no hospice agreement, patient under mechanical ventilation, full code, do whatever. And the patient is day by day by day by day there. Unfortunately, those cases sometimes ended up in the court if there is no agreement. We as a physicians, we have the right to say, hey, I want to take care of this patient. I want to translate this patient to another hospital. Yes, as long as you find another hospital that can take care of the patient. If not, it's yours. And then you can go to the court and say, hey, help me. I can do no more. But again, communication skills, it's a process. So basically, that is what we have. Ethical principles, very quick. Autonomy, all right? Talking about the proxy. When the proxy says yes or no, you need to ask, are you sure that this is your father's, this is what your father wants? The typical question, how was your father when he was, before this? He was independent. How was your father? And when usually family said, no, he was very independent, he likes to do this or to do that, then that's a tool that you have to say, are you sure that your father wants to, be on the mechanical ventilation? Are you sure? So that's autonomy, right? Always ask for any paper, for any living will, any healthcare designation, because we have seen cases where we don't find any proxy at all, no proxy. We had an ethical committee, and then at the end of the day, someone show up and say, hey, I have a living will. I'm his son. I was like, what? So always go for it. Ask for any paper or any advanced directive. Okay? So that's autonomy. And the other one that we need to have in mind is the beneficence/futility. So basically, implementation of any treatment that cannot achieve a therapeutic benefit for the patient in light of the patient's overall status. Are we having some benefit from, is the patient having some benefit from being connected? Yes or no? So those are the principles that we discuss with the family. Do you want me, Dr. Burgos, to talk briefly about how we perform the palliative extubation? I can go over. I promise this is the end. So I'm going to show you briefly how is the process, because everyone talks about palliative extubation. First of all, it's not terminal extubation anymore. The term is palliative or compassionate extubation. That is the current term, right? So this is a very nice reference if you want to go in deep. I just want to summarize. So palliative extubation consists of the withdrawal of mechanical ventilation when the absolute priority in care delivery is to afford comfort and allow for a natural death. It may be considered when all attempts at weaning from ventilation fail, and when keeping the patient with the mechanical support becomes futile, all right? It is also an option when the patient's quality of life is unacceptable and without any hope of improvement, right? So these notions should be reinforced such that the palliative extubation not to be seen as a way to accelerate death. Sometimes family asks about that, okay? And should not be performed when the assessment of the irreversibility of the patient's condition is incomplete. Again, we need to be very sure that the patient is dead or the patient is not gonna, go back to the normal situation is irreversible. We need to be very sure about that, right? So direct patient benefit is always the essential goal in the palliative extubation. So once the decision is made, we need to respect families' wishes. And I'm talking about, do you have any specific date where you want to go ahead and perform the extubation? Any specific ritual, any music? You want chaplain, you want a priest? Sometimes we see, oh, we are 11 siblings and we want everybody get together. You need to respect, all right? So if there are children involved in the process, we need to ask how you are going to address this considering children. How are you going to explain that to the children and this and that? And everything needs to be documented, right? And then we use some pre-medication, and the goals of the pre-medication here is to avoid, number one, respiratory distress, and number two, pain. Remember that we want to palliate the suffering, right? So we can use some pre-medication to avoid that. And then all the unnecessary equipment should be removed. NG tube, PEG tube, monitors, Foley, etc., etc., etc. So you remove everything, you keep the line, and you start with the pre-medication. And then you get the family involved in the process. Okay? Usually we pre-medicate the patients with two types of medication, opioids and benzos. Remember that we want to control, number one, respiratory distress that the patient is going to have for sure, and number two, pain. So these are the two medications, the two types of medications that we usually use. I'm not going to go over the doses because I think I don't have time enough to go over the doses. But just keep in mind that we use pre-medication before the extubation, right? And then there are two ways to proceed. Number one, terminal weaning or immediate extubation. So in other words, we can start by weaning off the ventilator parameters and then extubate. We can go ahead and extubate. So a recent prospective study that compared both found that immediate extubation was associated with higher incidence of obstruction, respiratory distress, and pain. So we prefer to start, weaning the ventilation parameters and then extubate, right? Who's going to perform the palliative extubation? That's a good question. Usually it's a respiratory therapist, but any physician that is well trained in the process can make it, okay? It's a physician thing, right? But in the practice, the respiratory therapists are the ones that usually perform the extubation, right? So we reduce the VO2 gradually. We reduce the PEEP to 5 or even less gradually. We take care of the patient. If the patient experiences any discomfort, any sign of discomfort, we adjust the medication. And then we finally remove the tracheal cannula. We wrapped the cannula in a towel, and we ask the family to come. We aspirate the secretions. We can use also scopolamine or usually scopolamine or any agent, anticholinergic agent for the secretions, either eye drops. We can use scopolamine for the secretions. We aspirate the secretions and we ask the family to come. That is overall the process. Patients who are stable, and it happens after 24 to 48 hours after extubation, may be transferred to a room, to a ward for privacy, okay? Family support before, during, and after the process, and finally staff support because we're human beings. That's the conclusion. Thanks for listening.
The question that you asked, just for the information. So the number of the examiners are varies based on, first, we said AAN, American Academy of Neurology, Neurocritical Care Society, and Board Project, Brain Desk Board Project. These are three guidelines. AAN says one examiner, Neurocritical says two examiner, Board says one examiner. Florida says two. So if you are, in different states, it's all varies. Usually when there are such a thing, most of the hospitals, each hospital has its own guideline. So mostly hospitals pick the most conservative, just to be, in the safe side. And the next question you asked was for the duration. The duration by AAN is not stated, so it's not over there. By neurocritical care is 12 hours for anybody above 30 days old, and it's not stated in the Board Project. It's not stated in the Florida, so it goes mostly to hospital. Okay, and one more thing that I was saying that, hey, do not pronounce somebody dead unless you know the cause. This is a real example. Just remember that I was talking to Dr. Sanchez in Palmetto last week, and he said, I'm never going to do that because of this. They brought me a patient overdosed, and he was over there for like 2-3 weeks. Absolute brain dead. So the first physician signed it, they asked me to sign it. I went, he's brain dead, no response I get. But the thing is, I didn't have a cause. He says, overdose, drug overdose is not one of those things that are going to cause brain death, So he said, I didn't have it. So I didn't sign it. And he said, guess what? 3 months later, he walked out. He walked out of the hospital. The paper was right over there to sign. And he said, after that, I never sign if I don't know what caused it.
One question, you don't need to wait 24 hours before starting the brain stem.
Based on what? No, not based on any, no, based on none of this organization, no. It's the hospital policy.
How do you say exactly that it's irreversible on the basis of the imaging?
No, based on all those criteria. You have a checklist. The AAN has a checklist. You go, you do test 1, test 2, test 3. All of them must be checked.
So the pathology, the cause is irreversible. How do you say the cause is irreversible?
The cause, like it was that the patient was cardiac arrest for 25 minutes, has a brain disease, has meningitis, has something explains it.
But it's still difficult to say for me. It's really irreversible. So yes, hemorrhage,
Hemorrhage.
ischemia,
And
or CPR.
one more thing, if they are on any medication, sedative or paralytic, 5 half-life should be passed.
And the other, do you do the brain stem reflection under sedation or?
No, that's not valid. There should be off sedation, off paralytic, off everything. You cannot do it if they're on. If any of those is going, it's not valid. Exactly. It's not valid. Okay, guys. Please.
It probably was a great presentation. It's
Thank
something
you.
that we commonly, not so common, but we see occasionally, and it's always a challenge.
Any questions from the Zoom audience?
When it's done, it's important for you in the training, because it's a challenge, and it's important. Even for the board, they tend to ask sometimes, when you have this component, what the unmet is, when it's done, contraindication for that. Go for definition of brain death. What's the definition of brain death? So why hospice is appropriate in this type of patient before the amnia test? Again, hospice is gonna provide social worker. It's gonna help the family, especially for the arrangements, because they are in a crisis. So it's difficult for them. The other thing is they're gonna provide chaplain and spiritual support. So that's are the components that are also very important. In addition, also some of the additional benefits in this situation. So again, thank you. I guess for any other questions, some of 2 hours presentation. So.
No, thank you, guys. That was a great presentation. Great work. And all the other programs, you're welcome to put all these together between different programs so we can continue to do these grand rounds monthly.
Thank you.
Thank you. And
Thank you
neurology
very
is always available.
Yes, of course. Good job.